Right. Hi, everyone. Today we're going to talk about health comm and culture. Um, Sorry if you hear some music in the background. It's Saturday night, and although I live on a residential street, there's a lot of college kids that live on surrounding streets, and they always blare music. So I'm sorry if you can hear that. I do apologize for it. I'm just trying to knock all these videos out so I can get them posted for you as soon as possible. So let's get started. Health and culture. So there is growing diversity in the US and globalization, and it has been acknowledged, which means that there's more attention to culture in healthcare. People are starting to focus on healthcare and the attention through diversity. The relevance of culture in health communication especially is important because of health disparities. So these are racial and socioeconomic distribution of health resources and outcomes, the haves versus the have-nots. And they're usually along racial lines, so Caucasians have better outcomes than others. And with this in mind, this is what your entire health disparity analysis paper is going to be about. So what I want you to do for this week is to save this PowerPoint to come back to it for that paper, because you will have to write a health disparity analysis paper. So health disparities are the differences between disease and health status, or in disease and health status between groups. So Caucasians, African Americans, Latinx, Asian Americans, lots of different groups. And when we think of contributors to the opioid crisis, what do we think of? Yeah, people become hooked. Let's take it to the opioid epidemic first, because we're all pretty aware of that. So people become hooked on opioids from prescriptions or on the street. A lot of opioid drug use started through prescriptions, and then they become dope sick. So what that means is they are pining for their next high. They got hooked from when they were on prescriptions, and now they're going to the streets to get their medication because they're dope, or not medication, get their drug because they're dope sick. And Big Pharma is pushing opioids. When they first came out, they said, yeah, no, they're not addictive. And that couldn't be further from the truth. And so, this next question, why are rural communities affected more than suburban or urban ones? Rural communities are more affected because there's often only one doctor in town. The opioids are prescribed, and then people take it as prescribed. And once they can't fill those prescriptions, then they start turning to the street, and they might go to more suburban or urban areas. But there are little towns throughout West Virginia where there's only one doctor, and it's kind of been a pill mill. So let's talk about culture. Culture is all about values, beliefs, norms, rituals, and everyday health practices that form base of a community. So given growing disparities, understanding and addressing underserved populations' culture can give entry point into improving health outcomes. So once we understand these cultures, we're actually going to be able to get ourselves into a good position for improving health outcomes. Health messages tend to be Eurocentric, individualistic, and biomedical. So these type of messages fail to address the lived realities and unique characteristics of cultural communities. So think about your culture and think about a culture here in America, but that's different than yours. If it's all one-sided, that leaves entire communities out. And the messages fail because they're not relevant or useful to many different cultures. So let's talk about cultural competence. What does it mean to be culturally competent? Well, it's the ability for healthcare professionals to demonstrate diverse values, beliefs, and feelings toward patients of all backgrounds, right? So they're not picking and choosing, I want to work with this culture, I will not work with this culture, right? But they're working with patients of all backgrounds. So, um, heart disease is higher in African Americans. Does that mean that we shouldn't check for heart disease in other races or backgrounds? Does that mean we should check all African Americans for heart disease? No. Like many of us have talked about, you know, I guess I'm just guessing, but we've talked about with people, we can make change and be proactive based on the environment, and we shouldn't just lump everyone together. but it can be a good starting point for communication. But cultural competence implies that the culture can be reduced to a skill to develop. So assumes that culture is a homogeneous and static state. Culture is always changing. It's usually made synonymous with ethnicity, nationality, and language. So Mexican culture, Chinese culture. Think back to at the start of the pandemic when Donald Trump kept calling it the China virus, um, the Chinese virus, and people stopped going to Asian-owned places here in Morgantown. They stopped going to Chinese restaurants. Some restaurants even had to close their doors. And this is why it's really important to be culturally competent because we have to be able to set those things aside. Be wary though, it's not really possible to set them apart to be culturally competent, or it could just be, or could it just be problematic? So think about that. Then we've got a cultural sensitivity approach. So we adjust our communication to a cultural perspective. We develop culturally appropriate programs and interventions, and we create and fine tune health messages that are responsive to characteristics of a given culture. So culture becomes the point of entry for understanding, interpreting, and developing interventions. It can be a really good starting point, but it assumes inaction because a message is culturally misunderstood, right? So if it's not nail on the head of a hammer, nope, hammer on the head of a nail, however that saying goes, it can be misunderstood very easily. So there are some assumptions with cultural sensitivity approaches. First, a culture can be itemized and reduced to simple traits and features. That's what we assume. We can reduce cultures to traits and features. The cause of disparity is only from information not being properly transmitted. We assume that it's not due to anything else, it is just due to information not being transmitted properly. Culture is static and consistent across individuals, meaning it doesn't change. It's one way, it's always that way, and it will be that way for every person. Another assumption is message substance can directly translate to another cultural context. So instead of listening to the message for a certain health behavior, it can be translated to something completely different. Now we're going to talk about a culture-centered approach, and the cultural perspective can only be told by those experiencing it. So I can't tell you African American culture. I can tell you what I've heard about it, but I don't experience it. It wouldn't make sense for me to tell you about that. Culture is inseparable from social structures and lived realities. This is where there's some intersectionality, right? So you got culture and you've got social structures and lived realities, and those often become intersectioned. They influence one another. Culture isn't part of that. However, it can intersect with the other two. They are two completely different topics, though. Social structures contain access to and usage of healthcare services and resources. So it's not just tweaking messages. So, how do these structures create conditions, or how do they create poor health? How do we change them to create great health capacities in communities? So, with the culture-centered approach, there's a few assumptions. First, culture is dynamic. It's always changing. It might even be fluid. Culture gives interpretive frameworks and cues to action. They tell us starting points and they tell us things that we can do specific to that culture. And fundamentally, they are tied to social forces and lived realities, not just the stories and values that are passed down. They are something completely different. Okay? Let's talk about structural influences on health. For structural influences, you focus on structures that draw attention to systemic inequalities. So these typically give rise to the simplistic culture outcomes that we often focus on. Individual choices are constrained by these structures and systems, and finding points of structural inequality gives target entry point for strategic communication. So with something like this, we know that there are systemically biased laws, policies, regulations, and they seem to apply for certain races, ethnicities, cultures, and not others. So, finding points to really get yourself in to understand those are important. Let's talk about structures a little bit. These are systems of organizing that enable or constrain uh, access, not across, access to resources, both material and social. So, um, the housing projects, right? Like how things are lined up. When people first came to America, when America started to boom after the First World War, the places that African Americans could live was systemically uh, unequal. There were systemic inequalities because they didn't have access to certain resources that white individuals did. And these include opportunities for health, housing, access to spaces of living, education, adequate and healthy food, spaces for exercising, and quality of healthcare. So, where do health disparities come from then? Well, globalization and privatization leads to unequal access to resources like income, education, food, and healthcare. So, if you don't have access to a decent living wage, right? You're doing the same job as somebody else, but they get paid a lot more. That can impact where you go to school if you drop out of school. The areas that you live in might not have access to um, clean and healthy food. And then healthcare. You might not have access to um, proper healthcare. And the inequality of unemployment and resources often lead to uneven mortality and morbidity rates. So unequal death rates. So with structural influences, we talk about neoliberalism and free market reforms that anticipate resources um, make it to those in need. Um, there are many inequalities that are created by neoliberalism, though. So they move away from rural areas to urban centers. They pull funding from less profitable areas. Different job opportunities are based on location, class, and implicitly race, and shaping healthcare by economic forces. So here in West Virginia, Black lung is very prevalent because of the coal mines. There's a roving testing center that travels across communities impacted by Black lung and makes it to people who need it. They travel to work sites. Blue collar workers can't always take off work to be tested, and this RV goes directly to them, and they can get tested while they're on the clock. So there are things that neoliberalism does, but they kind of assume that their resources are going to make it to those in needs, and that doesn't always happen. There are racial and ethnic minorities, as well as rural and poorer populations that have fewer healthcare options and fewer solutions available. So, healthcare options, or not options, healthcare outcomes decline due to the lack of prevention treatment resources, right? There's just not as many resources in rural or poorer populations. And they may not physically be able to, or they might be inaccessible due to social factors. I can't make it to a doctor's appointment because I have to take 4 buses to get there. That doesn't work for everybody. Not everybody has a car to jump into. Um, Cultural sensitivity approach addresses these disparities, but targets individual behavior to overcome barriers without addressing them directly, right? So we're saying, hey, there's these disparities, but you as an individual can't make it. Well, that sucks. I know what the disparities are. So there are 2 YouTube videos I would like you to watch on opioids. They're both 20 minutes in length. So go ahead and watch those. Health and culture, talking about the neoliberal take, is to push those in need to physical therapy or meditation or whatever else. However, there's no access to alternatives and or no insurance coverage for these things. So if they don't have insurance coverage for it, are they going to go? No, probably not. So some of the takeaways that I think are important from this lesson, Culture is fluid and not consistent across people. There is a shifting and dynamic values, beliefs, norms, rituals, and everyday health practices that form the base of a community. Cultural competency is outdated and not necessarily achievable. Remember, I said it might not be possible, but it also might just be really problematic. The influence of culture cannot be separated from social structures. So, culture does have influence, even though they are separate concepts. This is why we have intersectionality. And health inequalities have to be targeted structurally and systemically. So, we've got to focus on the structures and the system in order to overcome these inequalities. Takeaways from health inequalities, communicating to address inequality. Based on some characteristic, what is the inequality and what are the pathways that produce it? It's important to understand that question. What are the pathways? How does this inequality get produced? What is the role of communication in these pathways to the health inequality? Is it solely communicated and that's why it's an inequality? What's going on there? Sorry. How does the communication produce health inequalities? Communication is not perfect and it can add to health inequalities. And what communication strategies can address the underlying factors that produce health inequalities? So, this slide specifically, I want you to go back and look at when it's time to do that paper, because it's really going to tell you how to address the health inequality. And you have to think of a health inequality. All right. That's the end of health and culture. We'll cover health literacy next. If you have any questions over it, don't hesitate to reach out. All right, I'll see you in the next video.